so we have people going home to deliver care, and many of the elders obviously have found that very useful during the pandemic, because they've been cautious about coming out, but they need to be in continued therapy and rehabilitation. So, and we now, as you'll hear from Gayatri, we're going digital. So we've got a whole do-it-yourself model as well.
Oh, that's fantastic.
Supported model, yes.
That's fantastic.
In the call also is Yuvraj, who's going to be he's our chief physiotherapist. He's going to be our master of ceremonies today. So he'll guide us through the process. Dr. Salpekar and Dr. Evan.
Yes, nice to meet you.
Thank you. Nice to meet you.
We had quite some interest, over 200 registrations, so I hope a good proportion will join us to listen to what I'm very sure is going to be very exciting. One of the things I left out in my questions was treatment, so I obviously will talk a little bit around that as well during the webinar.
I think we'll cover everything.
Yes, broad scope.
Now it'll be fun. It's nice to have some time to carve out to actually talk about the overlap and some heady intellectual stuff.
Also of practical relevance, because so many people get concerned about the interface, including questions about silent seizures and all that. So, yeah.
Sure. Yeah. A lot of people are coming in. Good evening. There's actually just a day break here in Chicago, so we'll see the sun come up soon. If there is too much glare at any point, let me know.
It's actually nice to see a real city backdrop rather than, a Zoom backdrop of a city. So.
I thought it'd be fun. Although I have a little bit of a steam pipe that's behind me too, so that might obscure our view.
Dr. Rama has joined us. She's a clinical director. Dr. Salpekar, Dr. Evan. So it's 6:30. Shall we start, Gautam?
We are ready. We can start now.
Yes.
Yeah.
Okay. Yuvraj, please go ahead.
So good evening, one and all. Greetings from Buddhi Clinic. I would like to welcome everyone on the occasion of a Buddhi Clinic's 12th year anniversary. So first of all, I request our CEO, Mrs. Gayatri Krishnamurthy, to give the welcome address.
Thank you, Yuvraj. Good evening, one and all. I, on behalf of Buddhi Clinic, have great pleasure in welcoming our eminent guest faculty for the evening, Professor Jay Salpekar and Professor Joshua Evan, both from the Johns Hopkins University. A very warm welcome to all the audience who've joined us today to understand the brain-behavior interface. Before we move on to the panel discussion, I'm going to milestones on this occasion of Buddhi Clinic's 12th anniversary. Buddhi Clinic's social impact initiative, Buddhi Seva, supported by leading corporates and philanthropists, will touch over 200 lives this year. Next slide, please. So that's the Buddhi app. While many of our services have been made available online during the pandemic, we are now in the process of developing an app-based digital platform, Buddhi Online. Next slide, please. Buddhi Clinic in Coimbatore is now equipped with an OT suite to help restore to our clients the activities of daily living. Howard Gardner's concept of multiple intelligences, often used in corporate training, would now be integrated into the rehabilitation process of Buddhi Clinic, thanks to the guidance of Mrs. Usha Ramakrishnan. The membership program, our privilege cards offer a range of value-added benefits to our esteemed patients to help them with continued care. I'm very happy to now present the Buddhi team and would like to place on record our appreciation for their sincere efforts during these challenging times. Can we have the video, please? The Buddhi voices.
As Buddhi Clinic strides into its 13th year, together with our patients, we celebrate the holistic goodness of integrative medicine, which seamlessly blends ancient wisdom with modern medicine. Just as we take care of the brain and the mind, we also focus on lifestyle modifications, sleep hygiene, and gut health. We shall continue to strive to improve the quality of life and to offer relief and comfort to all our patients and their families who trust us with their care.
Rehabilitation is a medicine which adds life to your days. I enjoy rehabilitating the neurological conditions in Buddhi Clinic by redeeming them from the wheelchair.
At Buddhi Clinic, the state-of-art neuromodulation lab paving our way to the new frontiers of neuropsychiatric care which have helped the people around the world to rediscover the color of life.
We at Buddhi Clinic offer excellent psychological therapy support alongside neuropsychiatrists and neurosurgeons, and also practice a range of therapy techniques like CBT, REBT, etc. with our clients from all age groups.
Ayurveda, the ancient medical wisdom under the guidance of modern medicine, helps to restore normal functioning in Buddhi and Manas for the children, adult and elderly.
Relieving pain, renewing hope, restoring function. The name to trust for experienced pain relief center, Buddhi Clinic.
Electrophysiology evaluation is very important to diagnose neuropsychiatric conditions.
The brainchild of world-renowned neuropsychiatrist, Buddhi Clinic believes that their patients are the kings and the queens, of course.
Hire for attitude, train for skills. That's the mantra of Buddhi Clinic.
The future of healthcare is hybrid, personalized yet comprehensive, built on a strong edifice of patient experience, expert knowledge, and empirical research. Innovative, pioneering, and scalable, Buddhi Clinic's integrative therapy paradigm is here to stay. Truly Atmanirbhar in spirit, reflecting a bold, new, and confident India.
Thank you. Over to you, Raj.
Thank you, ma'am. So as we all are eagerly waiting for the clinical conversation on seizures and autism, so it's my immense pleasure to invite the speakers. First, Professor J. Salpekar, Director of Neuropsychiatry in Epilepsy Program and attending medical staff, Department of Psychiatry, Kennedy Krieger Institute, USA, full-time academic faculty, Johns Hopkins University, and courtesy consulting medical staff and Johns Hopkins Hospitals. He's got Child and Adolescent Psychiatry Fellowship at Yale University and has over 75 scientific publications to his credits. I also like to invite Professor Joshua Benjamin Evan, Associate Professor of Neurology at John Hopkins University, Associate Professor of Psychological and Brain Sciences, John Hopkins University, and also Krieger School of Arts and Science, attending physician at pediatric department both in Johns Hopkins Hospital and in Krieger Institute, resident of neurodevelopmental disabilities and child neurology, again John Hopkins Hospital and Kennedy Krieger Institute. He has got fellowship in clinical neurophysiology and has over 550 scientific publications to his credit. I like to invite Dr. S. Krishnamurthy, behavioral neurologist and neuropsychiatrist, founded at Buddhi Clinic. Over to you, sir.
Hello. Good evening. Thank you, Yuvraj. And once again, a warm welcome to everyone who's joined us today. In special, I'd like to welcome both our eminent faculty who have taken time off on a Saturday morning to be with us, Dr. Jay Salpekar and Dr. Joshua Evan. The webinars that we do and these dialogues that we do are meant to do three things. The first, to raise awareness about the importance of the brain and mind to professionals and a wider audience. The second, to get people thinking about difficult questions. And I think today, what we're going to do is talk about some very difficult questions at this interface, seizures, autism, neuropsychiatry, and behavior, and the role of the brain in all of this. So that's something that these webinars do. The third is to create a community of people who have the shared common interest in the brain and human behavior. And we do these webinars now 6 times a year. And I'm very pleased that this webinar, which comes towards the end of 2021, is also marking 12 years of our integrated brain and mind care effort. So it's a very special day, and I'd like to thank both Dr. Salpekar and Dr. Evan for joining us. I'm going to ask questions, and I'm going to let you respond in turn. I will not be specifying who the question is for, and I presume that that's okay with both of you. So let me begin by asking, what symptoms should lead one to consider and suspect autism in childhood? And how does one make that diagnosis?
Sure. Why don't I go ahead and start it out, and then I'll turn it over to Dr. Ewan. But as a preface, Dr. Krishnamurthy and everybody there, congratulations on 12 years with the Buddhi Clinic. It really is a spectacular accomplishment, and it's wonderful, the kind of facility that you have, which I have seen personally, and was very impressed, and a tremendous service, not just to Chennai, but all of India and truly the world, as I know that I have sent you patients from the US even to receive consultation at Buddhi Clinic. And I'm very impressed, and I'm very happy to participate in this webinar and to hear already from so many colleagues in India and all over the place. So it's a great pleasure to be here. And I'm very delighted to have my colleague, Dr. Josh Ewan, also here, who's an expert and scientist, and will help answer these and other questions as well. So anyway, in answer to your question, in terms of the symptoms of autism, the way that I think about it is that it's a triumvirate of sorts. We have 3 main symptom areas that seem to be most prominent. Now, perhaps the most important symptom area has to do with communication. There is some sort of altered communication. It's either a style of vocabulary, manner of speech, interaction. Sometimes it's an absence of communication or an absence of verbal communication. So usually communication of some sort is altered. The second main feature is some kind of social relatedness problem. So children and young adults also with autism, they may have pragmatic social difficulties. They might not read social cues, but more importantly, they may not be interested in relating with others socially. So they can avoid it. The social milieu is not a place where they are comfortable, and they may revert to isolating themselves and not interacting at all. And then the third main symptom area is some sort of stereotyped interest, activities, behaviors, sometimes even movements. So they might have a very narrow focus of interest. Just as an example, I've had patients, and I know Dr. Ewan does as well, where they're only interested in one topic. Maybe it happens to be trains, and trains are very common. We have our patients with autism who will memorize the train schedules to the exclusion of any other activity. And it's very difficult to engage them unless it is with their preferred interest. But the stereotype can also be transferred over to movement. Sometimes there'll be motor movements, extra wrist, arm, leg movements that can be repetitive or stereotyped in some way. And usually there's that pattern of either movement or interest that is prominent with autism. So I look at it with those three, and I'll let Dr. Ewan add if he wants to.
Thank you. And I'd also like to thank Dr. Krishnamurthy for the wonderful invitation and the opportunity to learn about the Buddhi Clinic. This is truly wonderful. I'll agree with Dr. Salpikar's answer. If I can add just a little bit to it, it's only to say that the presentation may vary a little bit depending on the age that we're considering, depending on the severity level, and also depending on the family's or cultural expectations. Let me take the last point first. I was giving a talk in France, and I learned something that I didn't previously know, because lots of my research has to do with the motor system, the movement abilities in kids with autism. And whereas in the US, as Dr. Salpikar said, it tends to be social aloofness, that was the word that was used a long time ago, or issues with language that bring a patient to attention, especially earlier on. In the French system, there's a focus on physiotherapy and the motor system, even in relatively small children. And what I learned there was that because of this focus, it may be the motor systems or the motor performance, the physical movements and abilities that bring children to attention before the social or the language. But with regard to severity, we of course see some children who don't speak and never learn to speak. And so they come to attention very early on when it would normally be expected that they would be learning to speak. For children who may be somewhat less severe, when they get into school, and as Dr. Salpikar says, they have these very specific interests that they want to tell you about over and over again, and their classmates are not excited to hear about them necessarily, these topics. That may be what brings them to attention in the less severe instances and later in life, in school age.
Thank you. If I can draw that further to ask about childhood epilepsy, which sometimes can be quite difficult to diagnose, and there could sometimes be an overlap. How do we, go about suspecting epilepsy in those difficult cases? And what do we see as characterizing, childhood epilepsy that's different from adult epilepsy?
Maybe I can start with this one and then turn it over to Dr. Salpikar. So in instances where there's a convulsion, this is, I think, very clear, and I don't think that there's anyone who would hesitate to understand that that may be a manifestation of epilepsy. And I think that's true with children who are otherwise typically developing. That's true with children who may have a known disability like autism or intellectual disability or cerebral palsy. And that's true for adults as well. Where we get into more subtlety is when there are attentional problems, in some instances, relatively rare, but they certainly exist. There may be some instances where we suspect ADHD, and then on further questioning, we decide to do an EEG because we might suspect absence epilepsy. In the case of somebody who has autism in regression, they were developing normally or close to normally, and then they lost abilities. They lost the ability to speak. They lost their social relatedness and the joy of interacting with other people, and became, more aloof in the old terminology. We very often do EEGs then because we're concerned about a situation where seizure activity that's in the brain but doesn't manifest as a convulsion may be very responsible for their autistic and language symptoms. So these are the more subtle cases. And then Dr. Salpikar very well pointed out the movements that may be repetitive and occur in, very typically in autism, we call them stereotypies. And sometimes it may be difficult to separate out what is a stereotypy versus what is a more subtle seizure, not a full body, both arms and both legs convulsion, but a more subtle seizure that affects just the arms, just the legs, one or the other. That's where questioning, EEG, and other sorts of things can help us differentiate.
Thank you. Dr. Salpikar, would you like to add to that?
I think it was well stated. I'll say sometimes it can be very difficult because seizures aren't always clear cut. And even on an EEG, if we have, and I'll let Dr. Ewan talk about that in more detail, but even on an EEG, sometimes it's difficult to interpret exactly what you see and how it correlates with behaviors that you see. We don't always have the luxury of having a video attached to the EEG so we can see both. And then sometimes when you have these movements or disrupted attention, it may not be a seizure. So it's trying to compare what you see with what the EEG correlate happens to be can be a difficult business sometimes. But I think that we do look at movements, change of consciousness, change of awareness, and interruption in activities as sort of our first clues.
Thank you. In fact, that's sorry, please go ahead.
Oh, yes, let me add one point to that. Something that I mention to families is that 4 years of undergraduate, 4 years of medical school, 7 years of postgraduate medical education could be boiled down to a pamphlet for many of my visits in the clinic. What I mean is this, that if we have children with ADHD, children with autism who have staring spells or may have staring spells that we know are not epilepsy, they may just be drifting in attention, very common in ADHD, for example. And I'm trying to differentiate that from an absence or a focal seizure that may be causing this change in attention or interruption in behavior, that I tell the parents, try to get your child's attention, not just calling his or her name, but pinching or something else, obviously not too aggressive, but something else that would certainly get their attention if their brain were functioning typically. And if you consistently cannot get their attention, then that is very concerning for seizures. And if you consistently can get their attention, then that's almost certainly not seizures. And that one piece of information is more useful than an EEG or inpatient EEG or any of these other things. It's much more helpful. And as I say, could boil down most of my training in that context just to this one piece of advice.
You've brought me to a very interesting kind of point. Many people say that, my child's face is out and I'm talking to him and he's not, or he or she is not answering, to my questions or seems to be ignoring me constantly. How are there other behavioral correlates that help you decide whether this is, am I dealing with silent seizures? Am I dealing with autism? What am I dealing with? Or inattention?
I just say pinch them gently. This is probably the single most important piece of, more important than EEG and all of this technology. Pinch them gently and you will know your answer 99% of the time.
So if the child responds to the stimulus, then you know that it's not a seizure. If the child does not respond to that stimulus, then you probably should consider this being a seizure. I have to ask another practical question to both of you. So when people give you this history and you say, okay, let's do an EEG, what proportion of children with developmental disabilities have an abnormal EEG anyway? That's one question. And the other question, most of our children end up needing to be sedated in order to have an EEG, which then means you can't correlate, even with the video EEG, a behavior to the electrophysiological event. So any comments on that?
Jay, do you want me to answer? I don't want to talk
please. No,
Okay.
Dr. Ewan, you are the expert.
Well, the EEG is a little bit my area, so I apologize if I'm talking too much. Right. So this is a very, very, very important question. This is a very important question. We know that children with autism, well, I guess for the audience, let me make an important distinction. That is, when we capture a spell during an EEG, our certainty in the answer is very great. Either we see activity in the brain that is associated with that seizure or spell right at that moment, or we don't. And that gives us, call it 97% confidence, yes or no. On the other hand, most EEGs are done interictally, and that means between seizures. And that gives us a little bit of information. I'd explain to parents this way, that if you have 100 pieces of equipment and one of them has sparks coming out of it, and you say, which one is likely to catch on fire? A fire being our analogy for the seizure. It's the one, of course, that's sparking, but it may be the case that the sparking machine will never catch on fire and has never caught on fire in the past. And so it's much more limited information. And I could give you lots of statistics about what it means this way or that way. But your very important question is that children with autism have probably 20% of them have these sparks in between seizures. And so if we see an EEG with these sparks and Mrs. X says, does my child, is he having seizures? We could say that the sparks, these characteristics of the EEG, either were there anyway, nothing to do with seizures, but just based on the fact that they have a developmental disability, or we could say that they're associated with the seizures. So it changes our thinking by a little bit, but not by very much. When we do sedation, let me say, correct that we often, for sedation, we use dexmedetomidine, which, unlike some of the other things, does not suppress the sharp waves and the spikes, what I'm referring to as sparks in the EEG. So that helps. We get, for the neurologists in the audience, we get beautiful N2 sleep, and we see sharp waves if they're there. So that doesn't hurt the interictal EEG, but this only lasts 30 minutes to 90 minutes to 2 hours. And certainly we can't get a 4-day epilepsy monitoring unit inpatient EEG where we have the hope of capturing the spells if they are not spells which are occurring on a regular basis. We also are very lucky to have behavioral psychologists who will work with the patients to tolerate the EEG. And so we use sedation very, very rarely, but it may be a delay in getting the EEG because it can sometimes take 1 visit or it can sometimes take 3 months worth of visits with our behavioral psychologists before their behavioral abilities are such that they can have the EEG.
Thank you. Jay, you've done a lot of work and you've written about behavior in epilepsy and childhood epilepsy in particular. Could you take us through that? What do we see in childhood epilepsy and how is that different from adult epilepsy?
Sure. Well, my entire career has been spent in this intersection or this overlap. Maybe it's a gap between psychiatry and neurology. And I've gravitated towards studying epilepsy because the overlap has been so significant with all of our brain and behavior relationships. The amount of psychiatric illness overlapping with epilepsy is quite striking and seems to be overrepresented. I'll give a little mention of Sir Michael Rutter, who just recently passed away, actually. But 50 years ago, he produced his Isle of Wight epidemiology study, which found that among children with epilepsy, the psychiatric illness was significantly overrepresented, sometimes 2 to 3 times as much as even another chronic medical illness. So there's something different about epilepsy. We see behavioral issues, cognitive problems, mood. It just seems to be more than what we see even in other children who've got asthma or diabetes. And I think it's more than just the threat of an impending seizure or lifestyle change, as you might see in diabetes. There's something about disrupting brain function that leads to psychiatric illness. Now, it's even more than that for adults, and I think that there's something about plasticity in children that maybe is protective in some ways. They can adapt and adjust. In adults, the comorbidity may even be higher, but we have less access to them because they don't have a parent or a school teacher who's noticing a problem and helps them to seek clinical attention. But I think it's at least on the order of a third in children who will have some kind of psychiatric illness along with the epilepsy. For adults, it may even be higher. I will say also, and we'll talk about this a lot more, because the comorbidity is so high in epilepsy, I tend to think of this as one illness, that we don't really have seizures plus a psychiatric, quote, comorbidity, but I think that whatever is physiologically wrong is leading to both circumstances, seizures, and then also, let's just say, depression or attention problems or whatever the case may be. Now, that's a huge paradigmatic change from certainly how I was trained, and Dr. Ewan, quite sure also. It's a distinct difference in how we approach things. Now, if we have a patient with epilepsy and we say we must expect some kind of psychiatric comorbidity and then treat accordingly and likely concomitantly, then we have a huge stride forward about trying to assess and address this comorbidity that we would not have studying things and treating these illnesses the old way. So it is a new paradigm, and I think that taking into account everything that we see behaviorally, psychiatrically, will actually help inform the epilepsy care, and the reality is it may be vice versa as well. So I'll stop at that point, but hopefully I've answered the question without too much digression.
Absolutely. In fact, I'm going to take the opportunity. You brought me to a very nice point in the Q&A. Someone has asked, how often do you have seizures in a person with autism? What's the prevalence of epilepsy in autism? And I'll extend on to that the question, what are the common underpinnings between these conditions that we are beginning to recognize?
Well, if I may, epilepsy occurs in the typical broad population, 0.5% to about 2%. That's the variation in the estimate. In autism, various papers have found very wide ranges, up to 60 or 70%. We don't truly believe those. I think most of us would say that it's 10 to 20%. And as Dr. Salpikar very nicely pointed out, the history of these two conditions being researched together, certainly this was one of the important findings that led psychiatrists in the 1970s to say that autism was not due to parenting, but is due to biology. The presence of increased risk for epilepsy certainly demonstrates that quite conclusively. In terms of the shared biology, the simple answer is nobody knows. what we know is as follows. There are currently about 1,000 risk genes for autism, and it will not be the case that such as Down syndrome, where there's a single chromosomal abnormality that leads to Down syndrome. There's a very tight one-to-one correspondence. In autism, it's not going to be that in most cases, there are a few cases where this is true, but in most cases, it won't be the case that a single gene is responsible for autism. It's really the whole recipe as it comes together of these 1,000 genetic ingredients. We know that of these 1,000, some of them are also involved in epilepsy as well. But I think our understanding is probably 100 or 200 years away from being able to conceptualize how the genetic puzzle pieces fit together, both for autism, for epilepsy, and how the autism and epilepsy puzzles merge. We believe that some of these are related to balance in the brain, balance between inhibition or the brake pedal and excitation and the go pedal. And it's very easy to understand how this might work in epilepsy, that there's not enough brake or there's too much gas, too much accelerator. And we think, or it's been hypothesized, that this is also the case in autism in a related way. Clearly, they have to be distinct because not every patient with epilepsy has autism, and vice versa. There's an overlap, but an incomplete overlap. But I think if we have this 100 years from now, we'll have a little bit more wisdom in terms of how these puzzle pieces fit together.
Thank you. Jay?
Yeah, I was going to add, I think that's interesting to think about, the future and how we can understand this. And, what I tend to think about with both of these conditions, and, Dr. Ewan, you alluded to it, is a hyperexcitability. There's something about, a brain in a child with autism that is just a little bit different in terms of connectivity, hyperexcitability. And we think that might in some ways explain what we see, to use Dr. Ewan's analogy, there's probably too much excitation. The gas pedal is a little too sensitive, and it's easily turned on. Anecdotally, sometimes we think that the stereotypic behavior or the sensory stimulation that many kids with autism will engage in, it probably reflects the need for these nerves to be awakened and activated, and they have to do something. They're restless. They have to do something. So we think about hyperexcitability, and anytime you've got nerves that are on a hair trigger that are easily activated, well, then you're going to be more likely to have these movements, these sensory stimulation activities, and also seizures. So that might be one way to think about it. I also think about connectivity. If autism is a disorder of hyperactivity or hyperexcitability of the nerves, and then increased connectivity, well, then you're adding fuel to the fire as well. So you have a lot of different inputs that can lead to these bursts or these seizures that maybe are focal in nature and sometimes generalized, or maybe they stay restricted to just one localized area, and sometimes are identified, sometimes they are not. But I do think that there's something about early development, and it probably is a genetic factor, or at least in part, the idea of hyperexcitability and connectivity that might be awry.
Thank you. There is a question in the chat box about, is the regular EEG enough? Should you have video EEG? Should you have QEEG in patients? So what's the kind of gold standard of diagnosis, the recommendation?
Yeah, if I may, in terms of diagnosing epilepsy, possibly the most important things that parents can do, as I say, is if it's a staring spell or a spell where we're concerned about change in mentation. Back when I practiced epilepsy for 14 years, the pinching trick is probably the most important thing in those instances. The second most important thing would be for the parents to take a video of the spells. And this doesn't require any particular technology. Beyond that, the thing that we can do that gives us the strongest answer one way or another, of course, is a video EEG that captures the spells. The lesser information, the one that still holds great uncertainty, is to do EEGs interictally or between spells. There are specific instances when you're worried about, for the neurologist, infantile spasms, Landau-Kleffner, other forms of epileptic encephalopathy, that a routine EEG can give you information that is highly important. So for parents or lay people in the audience, there are instances where a routine EEG will give you a 100% answer this way or a 100% answer that way. But for lots of spells, it gives you a 35% answer or an 85% answer, whereas the video EEG that captures the spell gives you the 97% answer one way or the other. Quantitative EEG is an interesting sort of thing, and I've spent lots of my research career working on it, and lots of my research career working on what type of evidence and proof we need to say that it works. And the problem with quantitative EEG is that when it first came about in the 1980s, it was perhaps a little bit more commercialized ahead of the science, and that the science wasn't done very strongly, and it was in some instances, commercial interests that sort of overhyped this and made it out to be more than it is. I would also say that quantitative EEG is not one thing. So I and many friends of mine in the research community have very specific things that we attempt to do to answer one question at a time with the quantitative EEG. It's not the answer to all questions. You know, can I detect a seizure that's happening on video EEG? That's a single question. In some people's research, in a newborn infant, can I predict which children are most likely to go on 3 years later to be diagnosed with autism or not? That uses entirely different engineering techniques, entirely different data sets. So it's quantitative EEG is not one thing that answers all questions. It's many different things, each of which answers a small question. And I would say for the use in epilepsy, only, I think, skilled practitioners, and this is much more common in Europe than it is in the US, I don't know about the state of affairs in India, that some signal processing on interictal spikes is proving to be very useful. For example, in epilepsy surgery cases, where we want to know the precise brain region that the neurosurgeon should go in and resect to take out. But this is very much we're at the base of the pyramid, if you will, where we're putting the pebbles together. And hopefully one day they'll all emerge to answer these broader questions that people are asking. So even though I'm a quantitative EEG researcher, I'm still very, very careful about how I would use it in the clinic, if I even tend to use it in the clinic.
Thank you. If I can share a little clinical vignette with both of you and how that led my thought process. This is a doctor's grandson who clearly, he was a teenager when I met him, and he clearly was high-functioning autism spectrum disorder. And he came with a profile of avoiding school, refusing to leave home for a year. He was a bit of a math geek, and he liked doing math. He didn't like doing anything else, what Jay was talking about, overinvestment in particular activities. What set him off when he left the house were sounds. And India, as you know, can be very noisy with the horns of blaring of the cars and things like that. So sounds were intolerable to him. The color yellow was intolerable to him. And touch was intolerable to him. And in all these three circumstances, he would have a behavioral outburst. And the only way he could avoid that was not leaving the house. So the school refusal began. And a year into this, he came to me. Very interestingly, had even just the routine EEG was very abnormal. Very interestingly responded very well to anti-epileptic drug treatment. He went back to being high-functioning autism spectrum, of course, but without these new problems that he had developed in the last year, which had made his life very disabling. And the happy ending to that story was that he ended up on an accelerated program in one of the Ivy League universities. And he now has seed funding for 2 startups, which he's managing from his Ivy League university. Obviously, it's not right for me to say which one. But from that and from other patients, I've always wondered whether hypersensitivity as a behavioral trait was a marker of brain activity, which helped us make some of these diagnoses. And I just want to sort of, kindle your thoughts on that. Is hypersensitivity a behavioral marker?
Well, I think I can probably start with that one. I do think hypersensitivity can be a marker, and certainly sensory issues, anything where stimuli can be irritating or overwhelming stimuli. And that gets back to what we think is happening with the brain. If there are hyperexcitable nerves or a lot of networks that are not well able to attenuate or basically adapt to rapidly changing stimuli, if that can be overwhelming, that's very common in autism spectrum. And I think that in a lot of ways, we probably have sort of qualities or characteristics of autism spectrum that are present in a great range, a wide variety of the population. Now, it's hard when we think about diagnoses or how to diagnose autism spectrum and at what level of functionality do we think the diagnosis really makes sense. There are some people who say, well, function has to be impaired in some way, otherwise we're not going to diagnose autism spectrum. Some people will say we'll still diagnose it, but we'll have different differentiators like high functioning versus other variants. So a lot of people will say high functioning autism. But I do think that a common thread and what often will make people resist interactions and having ideal function are these sensory issues, hypersensitivity. There are a lot of patients who can't go out of the house without wearing noise canceling headphones, or that will only go at certain times of the day. Maybe it's nighttime, so there's less to see and fewer stimuli. So that kind of thing can happen. I like your story though, because it seems to have a happy ending, and it does seem like even with these challenges, we live in a world today where we can actually be somewhat more remote, and the currency of success is less tied to social interactivity than it is to individual expertise. And so long as that's the case, I think that people who are on the autism spectrum or have features consistent with that will find a home, will find a niche. And that's probably true more now in the past 10, 20 years than it has been 50 years ago.
Thank you. It's a very positive way of thinking about it. And I'm sure that many people will take heart, when they hear you say that. If I can extend the question to ask, is brain imaging helpful at all? And I'm now opening it to both structural and functional imaging. And I'm asking about diagnosis, and I'm asking about differentiation. I'm sure many people are interested.
Yeah. Dr. Ewan.
Yeah. Brain imaging is not useful to diagnose autism. However, in somebody with autism, there may be instances where you're looking for one particular genetic syndrome or another, that the brain imaging, now talking about structural imaging specifically, is very useful in terms of giving evidence that would lead you to one's genetic syndrome versus another genetic syndrome, and may be useful even in addition to genetic testing itself, to testing the DNA or chromosomes. It is not useful for diagnosing whether somebody does or does not have epilepsy. that's based on the clinical skills and, pinching or videos, video EEG, and so on. But if somebody has focal epilepsy, meaning it comes from one part of the brain, then almost every patient then should have an MRI to look for lesions, whether it's a tumor, abnormal blood vessel development, abnormality of brain development, so on, that could be causing those focal seizures. So it really doesn't help us diagnosing either epilepsy or autism in itself, but is a second order beyond that. Functional imaging, to my knowledge, and I'm very strict, I would say, about the type of evidence that would be needed before I would order a test to prove that this test does in fact tell you this or that. In fact, I've made part of my career as being a gadfly in sort of exploring what sort of information should be known before we recommend these tests. But I think that functional imaging, the only real use, and Jay probably knows more about this than I do because of his involvement in surgical cases of epilepsy, is before an epilepsy surgery, we want to know that the neurosurgeon will do two things. Number one, remove portion of the brain that is responsible for the epilepsy and will cure the epilepsy once it's removed. And number two, doesn't remove an area that's important for language, for movement, for perception, for memory. And we know that functional imaging works fairly well for giving us this answer about language and to a lesser extent about movement. And we know that it's very bad for giving us information about memory. So functional imaging is indeed useful only in these circumstances where an epilepsy patient, whether they have autism or not, is going to go for epilepsy surgery and figuring out the borders of where the neurosurgeon is safe to remove.
Thank you. Sorry, Jay.
I was just going to say I agree with that, and I think that the hope for functional imaging was that it would replace other procedures that were more invasive, the WADA tests and other things like that, or the long extended neuropsychological evaluations. There was hope that functional imaging could help us with that and be able to localize language function so that could be avoided by the surgeons. It hasn't quite worked out like that, but it's making progress. It's getting better than it used to be.
So there is hope with functional imaging as it gets better.
I think so.
There's a very interesting question in the chat box from Dr. Rekha, who's asking about the interface between tics, seizures, and autism. Would anyone want to respond to that?
Wow.
Would you like to?
Sure. Tics are difficult because we're not very good at describing tics per se. I mean, we can describe them phenomenologically, but in terms of a tic disorder, or what is the overlap between a developmental phase for tics. I mean, a lot of kids will have tics, maybe a quarter of them will have a period of time where they have even complex motor tics. And then they go away. And the natural history of tic disorders is to wax and wane. And sometimes they're exacerbated in conditions of stress or illness or other developmental hurdles. But the overlap and the differentiation between tics and seizures sometimes can be difficult. But I think not to encourage pinching, but that would be diagnostic. Of course, if a child is having a tic and you pinch them, they'll get more irritated. They might tic more. I think that the awareness certainly is not disrupted for tics, not that we see, but they are for seizures most of the time. Certainly if they're a focal seizure where awareness has changed, then the awareness will change a little bit. In terms of the autism overlap, well, these are hyperexcitable brains. There are connectivity issues, and sometimes tics have to do with motor control or inhibition control. And if those networks are immature or ineffective, well, then you're going to have more tics that build up and develop. the imaging for tics per se is very interesting, and that there are two main components, and one is that there's a prefrontal problem where you've got this suppression, and you can see actually larger regions of the prefrontal cortex for people who've had tics for many years, and they are volitionally trying to suppress their tics, and you see increased structures in the prefrontal cortex. And then sometimes you see problems with the basal ganglia, the caudate nucleus, parts of the brain whose job it is to inhibit motor output. There's also cognitive output that is modulated by the basal ganglia too. So you can get these types of structural brain problems. Now, whether that's causal or the result, very difficult to tell. But I think that you can see that level of connectivity that maybe is an overlap. Otherwise, we don't see the overlap as prominently if we call most of the behaviors we see in the autism spectrum stereotypy versus tics. And that might be a nomenclature issue as much as anything else, because tics can range quite widely from simple motor to complex motor. Sometimes there are complex motor activities that are blended together. So the awareness is usually key in differentiating it from a seizure disorder versus not, but it's very difficult to differentiate a tic from stereotypy that you'll see in autism spectrum. I don't know, but I'll let Dr. Ewan talk about how do you do this?
Well, I think specifically tics versus stereotypies have somewhat different patterns to them. And Dr. Salpikar, you've hit on many of the important points that with a tic, as you note, they tend to come and go. So patients may have tic A, let's say it's throat clearing. They have that for a while and it may come and go, but before it regresses, maybe they start to develop tic B, like let's say a blinking tic. And that increases when the throat clearing falls off. And so on and so on. That these tics evolve over time and tend to overlap. Stereotypies, based on their name, they're stereotypical, tend to be the exact same throughout the child's lifespan. Also, stereotypies tend to develop earlier, before age 3, whereas tics are later, after age 3, and very likely into later childhood. In terms of the environmental circumstances that would lead a child who has tics or stereotypies to have a tic or stereotypy right now. With stereotypies, it's very common that it's either excitement or boredom. That's sort of the black and white, but either of those things can cause stereotypies to occur right now. With tics, it's a slightly different flavor. The increases in stress typically cause tics. Also, people who have the verbal abilities to be able to report on this would say that tics can be suppressed. So people who experience tics first experience this pressure to have them, like a pressure to sneeze, that they can suppress, but it takes effort and energy to suppress them. And so, for example, if they're visiting their parents' friends and they want to put on a good appearance and not have a tic, they can suppress it. And then once they're alone in the car with their parents, they'll have lots of tics that sort of, to release all of this pressure, if you're holding a sneeze in, and then you sort of let it go. Whereas stereotypies, I think, are less, it's less possible to suppress them, and I think people tend to be less aware of them. Unlike a sneeze, it's almost more like breathing, I think, is sort of the description. So these things have different flavors. And of course, tics are amenable to the medications that we prescribe for tics that we could, of course, discuss. But stereotypies tend to be more amenable when possible, either to behavioral therapy or in some instances, just social acceptance. If we accept that child so-and-so will do this with his hands when he gets excited, and his friends aren't upset by this and his parents aren't upset by this, and it just happens, and this is a normal behavior, then that might be the best intervention of all.
Thank you. We talked briefly about genes, and you talked about the diversity of genes in autism and the kind of overlap with epilepsy. Are there specific syndromes which, they sort of exemplify the seizures autism interface? Have they been described? Could you tell us a little bit about them?
Tuberous sclerosis is probably number one for that. There are others that we're learning more about, but the one that has a very long history being described over 100 years ago, well researched, is in fact tuberous sclerosis, which is a result of the mutation of one or two different genes, leads not only to, in many cases, to autism, not only to epilepsy, and the fact that children with epilepsy are more likely to have autism and vice versa either tells us something about how the gene functions, or it tells us about the ability, for example, of epilepsy activity in the brain to cause autism symptoms, and we don't really know the answer to that yet. But it's also involved with a number of other things, tumors in not malignant cancerous tumors, benign tumors in the heart, kidneys, and lungs, as well as tubers, not tumors, but tubers with a B, in the brain that are non-cancerous growths. And what we know is that children with tuberous sclerosis may have many of them, and the area around the tuber, not the tuber itself, may be miswired in such a way that leads to the electrical activity that causes seizures. And so it's very common to attempt to figure out which of the many tubers in an affected individual is causing the actual seizures, so that that precise tuber and not the many others can be resected by the neurosurgeon, hopefully to improve the epilepsy.
Thank you. One of the most important things that people are concerned about is treatment. What can I do to help my child? And the treatment of behavior in particular can be quite challenging for people, because they also wonder whether they should give a medicine to make things better. So drug treatment can be quite challenging for people to accept. So can I get you both to comment on the importance of drug treatment and when it should be avoided, and the importance of non-pharmacological treatments? Someone's actually asked, is multidisciplinary care important in neuropsychiatry? So if I can get you both to address that based on your rich experience, that'd be very helpful.
Sure. Yes, I would agree. I think that non-pharmacologic strategies, behavioral, structural, educational, there are many opportunities to address this overlap quite effectively and efficiently. When you have someone with autism spectrum plus epilepsy, it requires a team. And it's a team not only of parents, but also of advocates, educators. And the reality is that we have to be creative. Now, there are a couple of rules of thumb. And one is that structure and routine are usually better. If we have a predictable routine, if we build in break times, relaxation space, if you will, build in movement breaks, also where people can get up and move around, and set some reasonable expectations. The reality is that you don't have to have scheduled activities all the time. Sometimes you schedule no activity and schedule downtime as well, and just allow a varied approach in that way. The other thing that structure allows you to do, and by structure I mean having discrete tasks through the day that are at the same time, same routine. If you have structure in place, then you can allow a child to earn privileges and to have good behavior and then reach a desired reward at some point through the day or even multiple times in a day. And as long as these are small rewards that are scattered throughout the day, that's usually much more efficient than having a grand prize at the end of the week or something like that. That the attention span to go for the grand prize sometimes can be very limited, but it can be effective if you just give smaller rewards through the day that maybe even can be aggregated into some bigger reward. So I think structure and routine is very important. Now, medicines are a mainstay still, but I would add that usually medicines are to address some target symptom. And what we end up assessing a lot of times is aggression and impulsivity. And certainly if someone has aggressive reaction, that's something that often requires a medicine, particularly if the aggressive reaction is spontaneous in nature. If you have someone who very suddenly escalates, or even when they're happy and comfortable, out of the blue starts having disruptive behavior, well, that's probably reflecting some sort of control system in the brain that is awry, and maybe that requires a medicine to stabilize. And we can talk, I'm sure we'll talk more about medicines, but that's how I think that I'm in medicine territory, is if I have that level of behavior disruption, and I've already done things or worked through things like structure, routine, rewards, facilitated communication even, and then other non-pharmacologic strategies. But I'll let Josh weigh in on this too.
Thank you.
Yeah, by all means, for epilepsy, of course, medications are the #1 treatment. They are effective in about 60 to 75% of individuals. In terms of when we use them and when we don't use them, it's in a sense almost very simple. When the benefits outweigh the negatives, then we would use medications, and when the negatives outweigh the benefits, then we don't use the medications. This is probably more likely a calculation in patients with behavioral conditions than without. I've known some who, well, let me say this, I want to make sure that the context is right. 90% of the time in my experience, the benefits in behavioral conditions outweigh the side effects of the medication. But there are a few cases where the side effects, even when you try many different medications, are always worse than the amount of improvement that you get, and how that improvement impacts your life, impacts the life of the family. So Jay may have a more experienced number for that. I would say for epilepsy, 97% of the time, 98, 99% of the time, the positive effects of the right medication outweigh the side effects, and the notion of giving up medications altogether because the side effects are so bad, even if you tried multiple different medications, is very rare. I've probably seen it in my career, I don't remember, but really it is just this balance of, are the side effects worse, or is the symptom, seizure, or behavior that you're treating worse for your life? With epilepsy, there are other non-pharmacological measures. There's the ketogenic diet and things related to the ketogenic diet. Atkins has been tried and so on. Other variations. There's the vagus nerve stimulator. And there's different types of surgery, mostly to remove brain tissue, but some others where electrical stimulators are placed in the brain that can detect the seizures, and then, like a heart pacemaker or heart defibrillator that's implanted under the skin, these are also implanted and can, in some cases, detect seizures and stop them. These are only prescribed for a small number of cases, and they don't work in all cases. There are other non-pharmacological therapies that are, oh, I think I might have frozen. There are other non-pharmacological therapies that are being investigated now to see if they're effective and safe in epilepsy. Deep brain stimulation, it's a different type that's previously mostly used for Parkinson's, but may be helpful for epilepsy. And also TMS and other forms of neuromodulation are things that people are studying right now to see if they're safe and effective. But overall, any therapy, if it's creates more benefit than it creates harm, then it's good. And in some small cases, it may create more harm than it creates benefit, and then you stop the medication.
Thank you. There's a question in the Q&A box about TMS for autism. Jay, would you like to answer that? Any evidence for use of TMS and other neuromodulation techniques?
I would be delighted to turn that over to my colleague, Dr. Ewan, actually.
Yeah. No,
Dr. Ewan.
I think it's very promising, but I don't recommend it for my patients yet. There's lots of research, there's lots of enthusiasm, there's lots of anecdotal evidence. I myself am writing a grant to study a certain type of TMS in ADHD, and we have some preliminary data that's very exciting. But in certain instances, so there's somebody who's created a foundation in the US, the mother of a child with autism, who underwent a TMS trial, time flies, almost a decade ago, I think, at Harvard, where her son received great benefit. Unfortunately, none of the other children in the study received benefit. And so when you put the statistics together, this child was an outlier, and the conclusion was that there was no benefit when you average across all of the children. But she was so moved by by her child's improvement that she started a foundation to try to promote more research. And I think what we don't know, this is a major challenge in autism, ADHD, intellectual disability, and all of the adults and children, Dr. Krishnamurthy, that you treat with all of these different conditions, is we describe these conditions like autism by behavioral features, which we might call superficial features. But it's very likely, as I described, that there's this genetic recipe that we don't fully understand, and if the recipe is a little bit different, we don't know whether it's the onions or the tomatoes in one case, and it could be that one ingredient may be different in one individual that has a very different biology than another individual who has a different ingredient or a different gene. And that superficially, they may have the same symptoms. They may interact with their family the same way. They may have the same learning issues in school, but their biologies are radically different, so that a treatment that's very effective for number one is going to be ineffective or dangerous for number two. And just by looking at their behaviors, which may be the same, we don't know how to divide up number one and number two. And so lots of the things that we're working on with quantitative EEG and other biomarkers is just finding some way to stratify so that we all have patient number one, you know, the caused by the onion in the recipe, together in a trial, so that maybe the TMS will be very effective in these patients. And our, you know, I hope my analogy isn't too silly, the tomato patients, you know, category B of biology, maybe the TMS doesn't help at all, but maybe something else does. And when we mix them together, unfortunately, in these large trials and do our statistics, we fear that maybe a true benefit in a small group is being washed out by an absence of benefit in these other groups. So lots of research attention is focused in this area of stratifying for these clinical trials.
And I suppose with most of our treatments as they stand today, whether it's drugs, whether it's our non-pharmacological interventions, whether it's brain stimulation, someone's asked about TDCS other than TMS. I guess at the end of the day, we are treating the symptom, isn't it? Like you said, the symptom may be a tomato symptom or an orange symptom, but we are treating the symptom using a technique which may end up working for one and not end up working for the other. So, but that's true for our drugs as well, which is what is very interesting to me. You both have a large experience of working with people for years. So any pointers about prognosis? Who does well and who doesn't do so well in your experience when you encounter patients with these combinations of symptoms?
Sure, I can start with that one. I think that the easy answer is you do well if you confront the problems directly. And I think that the hard part is people who do not avail treatment opportunities, or maybe put on blinders and try to avoid problems or avoid considering or confronting the problems. So I think I would encourage people to make use of the resources available and get some consultation, get help, get opinions, get multiple opinions. I think right away, if you do that, if you are bold, because sometimes it requires some bravery and boldness to acknowledge that something isn't quite right, that some behavior is problematic. And a lot of places in the world, a lot of cultures, it's very difficult to acknowledge that there is a problem. So I think that's step one. And then step two, in more specifically, I think anybody with autism spectrum that can learn to communicate is going to do better. And I'm an advocate of teaching facilitated communication. If it needs to be sign language, it can be sign language. There's some wonderful technology now with assisted speech devices and language generators. And I have a lot of patients who are quite skilled with using some of those things, and even making complex sentences, which we did not think the person was capable of doing, can, with a speech generator or an assistive technology, can actually communicate much better. That's usually how communication is how we interact with the world, and it is how an individual is going to grow up and be efficacious in their environment. If they can communicate even on a rudimentary level, then they're going to do better. So that's the clearest thing. And then, of course, being able to address medical issues, seizures, everything else as they come up, and being somewhat aggressive about treatment, not necessarily passive. I think that you want to be very deliberate about having a treatment plan that includes pharmacologic and non-pharmacologic treatments, but emphasize the communication, because the people who I see, the kids who communicate better are the ones who function better and do better in the longer run.
Thank you. Josh?
I'm not sure that I have very much to add to that wonderful answer. I agree. Communication is fantastically important. When it comes to the prognosis related to epilepsy specifically, I wish I could tell you who will do well, who will have a strong improvement for medication, and even after a period of 2 or 3 years with 0 seizures, and then a subsequent EEG that is perfectly clean, that they can successfully come off of medications, but I can't predict it one bit. I have some patients in my history of practice who responded immediately to medication, never had another seizure, even on a very low dose of medication. 3 years went by, not a hint of something that parents were even slightly concerned about was a seizure. Did an EEG, it was perfect. Took them off and they had another seizure. I wish I could predict who will successfully come off seizure medications and not. And then I've had some patients who are very challenging to control, and it's 6 medications before there's any possible effect, or one without any side effects. And it takes lots of ramping, and then over time, they're the ones that 5 years later are off medications and have no more seizures for the rest of their lives. I wish I could tell you, but I can't.
If I may, Dr. Ewan, I have a question for you. Now, we have this idea that if you've not had a seizure for 2 years, then it's time to try tapering medicine. Do you think that still holds true, or that we ought to be revising that?
Well, I'll give you my answer, then I'd love to understand what your experience is that causes you to question that, because even though you see them for different reasons, you've probably seen more patients with epilepsy than I have. So I'll be very interested to know your answer to the question of why you're asking this. To my mind, the literature shows us that if a child has been seizure-free for 2 or 3 years, either way, 2 or 3 years, and you do an EEG and there's no evidence of these sparks that I was talking about earlier, for the neurologist, sharp waves or spikes, intrarectal epileptiform discharges, not that it's proof that they will successfully come off of medication. Believe me, there are lots of patients who meet all of these criteria and still have seizures once you withdraw the medication. But it merely means that if you take them off medication, slowly wean the medication at that time, after 2 or 3 years, seizure-free, clean EEG, there's no greater risk of them having recurrent seizures once they're off the medication compared with when you, if you were to wait 5 years seizure-free and take them off. So there's always a risk that the seizure will come back. It's just that that seizure risk is the same if you take them off after 2 or 3 years, or if you take them off of 5 years, and presumably, we don't know, but presumably if you take them off 15 years after being seizure-free. But Jay, back to you. What are your observations that lead you to question this?
Well, I think my observation is that I didn't necessarily think that 2 years, was sort of a hard and fast rule. I mean, the literature makes sense, 2 or 3 versus 5. But my other question is the taper schedule too. And there's a lot of variability, and I'm wondering if that overlaps into this idea that, well, maybe we can grow out of seizures if you've been stable and no EEG changes after 2 years. But then the taper schedule, and sometimes I get into trouble with that, where I might taper it down too quickly, and I think, well, is it a matter of time, or is it just I'm tapering too quickly? And that's what I struggle with, when I'm at that point where I want to take medicines away, and because I think they're stable.
No one knows about taper schedules, and this is just a matter of the neurologist's personal preference. I've had patients that have maybe seen X number of other neurologists in the past, and I say, okay, well, let's taper over, 2 months. And they say, well, but my last neurologist tapered over 2 weeks. I say, I can't prove to you that my way is better. It's just, how I trained, and it may be the same. And then if you look at the actual package inserts, that are the official in the US, the FDA, Federal Drug Administration, what the information has to be in the package, it says, goodness, it's ridiculous. Well, I don't want to say it's ridiculous because we don't know. It's like 4 months that you taper over, but that's not based on science that shows that 4 months is better than 2 months, is better than 1 month, is better than 2 weeks. It's just based on lawyers saying, well, what's the most conservative, safe thing so that we don't get sued? No one knows. No one knows, and I do it my way, and I feel strongly about it. And neurologist X may do it her way, and she feels strongly about it, and we don't have any data to say that she's better than me or I'm better than her.
So the kind of things that we tend to emphasize in the Indian setting is the importance of the teamwork, multidisciplinary care, because it's very difficult for doctors practicing alone to look after most of these patients. We do tend to emphasize on the importance of the Therapeutic Alliance, that the patient's family, usually, not just the patient, and the medical team are constantly talking to each other and making sure that they're on the same page about what they're doing. And if there's a very involved family, who are very keen to help, that often is very, very important, because that ensures there's some consistency in the effort. They keep bringing the patient back, and Indian families tend to be very involved, which is something that we tend to appreciate, because we can't remember and call back all our patients. In a way, to a very large extent, it's up to the families to make sure that they keep coming back to the team. Finally, the one thing I keep telling all my patients is not about what what your family member who's our patient, or what you yourself can't do. It's about what you can do. Because so much emphasis on what you can't do when we assess we find problems, we find gaps, we find disabilities. But there is also ability, there is interest, there is scope for improvement, which often gets ignored. So that's something that we keep emphasizing, that please focus on what the person can do, not on what the person can't do. Those are our long-term indicators. People who think like that, we find, and act like that often seem to do well in the longer term than in the short term. So I'm going to leave this with both of you with one final message for families and for public health. We've talked about a very important domain of concern, brain development and disorders of brain development and behavior and seizures. So, your words of wisdom.
Jay, you're wiser than I am, so I'll defer to you first.
Well, I'm not sure. There might be some controversy, so not everyone would agree. But I do thank you for that, and I think I would encourage people to be very bold about confronting these issues and acknowledging that there's something that is not quite right. And I think that certainly with autism spectrum, it takes a long time for a family member, a parent, to assess that things are developmentally not quite right, and they might suspect that things aren't quite right and be very hesitant, very afraid because of the implications. I think the reality is that you want to get help. Get advice, get help, consult. It doesn't mean you have to agree with everything, but at least that you have the opinions, you have the advice, and then you can make a decision about how to treat. And then the other point is that combine the efforts, combine the treatments. There are many things that you can do. And Krish, I really like the way that you put it. Let's think about what we can do. There are many things that none of us can do. There's a lot of things in the world we cannot control. We can't be worried about those things. We have to focus our energies and our efforts and invest our time in the things that we can control. And for anyone with this combination, with autism spectrum, with epilepsy, there are many things that we can do. We can make improvements in communication, in medical stability, in the environment. All of those things can be done, and I would just emphasize, be optimistic about how effective you can be.
Thank you.
Yeah, I'm not sure. I'm not sure I'm fully up to this task, but I'll say this: disabilities like autism, of course, are social constructs. As I like to say, if I lived in the world of the bird people, where it was expected that I should have wings and be able to fly from one perch to another, I would have a disability. And I think it's, in that sense, many of the happiest families, which I think is in the world of developmental disability, what we're really aiming for, are the ones who are able to focus to the greatest extent on the positives of their child, their individual characteristics. This is not to make light of the challenges, because there may be medical challenges, there may be very severe behavioral challenges that no amount of acceptance and love can overcome solely by itself. So I don't want anybody to feel guilty if this is a challenge. But I would agree with the point about having optimism, and I would help people focus on their individual child, his and her personality, and the many positives as well that may be different from their initial expectations, and to help others see the positives in their children and what they are able to do. And beyond that, I think a great lesson learning about the Buddhi Clinic today, as Dr. Krishnamurthy said, is the level of integration. And at Kennedy Krieger in Baltimore, we have this very same philosophy. just out of medical school and my residency, I thought I knew XYZ about this or that, but I meet a physical therapist. They know so much more about movement than I ever will. And even though I'm a movement researcher, there are so many wise physical therapists who will know so much more about movement than I ever will over the course of my life. Putting the team together, keeping everybody on the same track is a philosophy at our institute that I don't want to say is unique in the US, that would be a lie, but I think it's true that we take great pride in this, as you also take great pride in it. And I think all of us who are involved in multidisciplinary care can see very evidently before our eyes how important that this teamwork is for helping children and families.
Thank you so much, Dr. Jay Salpekar, Dr. Joshua, even. Thank you so much for your enthusiastic, insightful, and thorough and detailed answers. I think you took us through a lot of information today, and not just for the people who are here today, but I think those who will watch this webinar on YouTube in the future, they will learn. There are several questions left unanswered, but I've left our email address for people to email us, and we'd be very happy to try and help with some of those questions. And there's also a phone number in case you need to WhatsApp or ask a question. I'm going to thank you once again, Dr. Salpekar, Dr. Evan. I'm going to hand us all back to Yuvraj. Thank you.
Thank you, sir. It was really very informative, and I hope many things would have been revealed for most of us. And now I'd like to call upon our clinical director, Dr. Rama Raghu, to present the Buddhi Clinic's approach towards children with neurodisability, and also I request her to conclude with the vote of thanks.
Thank you, Yuvraj. I hope it's visible.
Yes, ma'am.
Good evening. I'm bringing up the tail end of the program. The integrative concept of Buddhi Clinic widens the horizon whenever we come across a beneficial therapeutic intervention, and we include that in our therapy armamentarium. So one of the modern interventions, the cutting edge intervention from neuromodulation, has been the transcranial direct current stimulation, and discussions about which we heard earlier. It is an intervention which uses electric current. It is non-invasive, it is safe, it's an outpatient intervention, and it is used to regulate cortical activity. And it can be very easily integrated with many other therapeutic modalities. And clinically, we have seen that it reduces restlessness and agitation, and it reduces repetitive behaviors and improves speech for non-verbal patients. The next is the concept of multiple intelligences, and we've had a lot of guidance from Mrs. Usha Ramakrishnan, who's part of our audience. Thank you very much, ma'am. And this is based on the concept that each of us has a unique profile of a combination of intelligences, and you can see there are 8 distinct ones listed. So we have learned that we need to understand how a child is in its natural surroundings. So we request the parents to send us videos so that we can understand the activities of the child better. This also helps us build rapport with the child and the family, and it helps us create new pathways in our therapeutic programs. We've always been using the complementary and alternative therapies, the Ayurveda and the reflexology. We found that it's particularly useful in improving gut health, especially constipation, and it helps relax the child, and it helps build the initial rapport that we so much need. So this is a coming together of a basket of therapies. I've spoken about the neuromodulation, but for a child with autism or children with various neurodisabilities, we also have psychological interventions. We have the speech therapies, and we have the yoga therapy. And very important, as we always reminded, that the sensory issues that a child has should be addressed very carefully. It should be identified and addressed, and the physical therapists play a very important role in this. And as Dr. ESK said, I think it's very, very important that we have a committed engagement between the treating team and the family, because together we want to achieve the therapy goals that we've set in the beginning. I will stop sharing now. And as we come to the end of this wonderful evening, I have the pleasant duty of proposing the vote of thanks. And I would start with thanking our wonderful speakers, Professor Jay Salpekar and Professor Joshua. I think you've simplified many neurological complexities regarding autism and seizures in an hour and a half. Thank you very much. And a big thanks to Dr. E.S. Krishnamurthy, who brings such luminaries in for all our dialogues. Thank you so much for being the ever wonderful moderator. And thank you very much, Marundishwara team, for coordinating this event. And our wonderful audience. You've been with us each and every time. I hope you're learning more and more with every exchange. And the Buddhi Clinic team, thank you so much. And as we learn to peacefully coexist with all the mutating viruses, stay safe, everyone, and wishing all of you a healthy and prosperous new year, 2022 to look forward to. Thank you so much and good night.
Thank you.
Thank you, ma'am.